Right, so we'll get started with our next session. It's my pleasure to introduce Dr. Tarasaria with us. Dr. Tarasaria is a vascular neurologist at Atrium Health who's recently moved here, and we are glad that he's here to help work with us for our FMD patients, who's going to talk on headache and FMD.
All righty. Good morning, everybody. Thank you, Dr. Sharma. Thank you, Dr. Kim, for having me here. Through the morning, as we've heard some of the stories and some of the other talks, I really do feel grateful for some of the stories that have been shared here. I think we all have our own stories. We all have a journey that we've been through, and I think it's just such a privilege to kind of hear some of the stories this morning that I've heard. And also, I think it kind of highlights, the work that me and my colleagues do, but at the same time, what the perspective of somebody in the shoes of somebody who has FMD kind of has to go through, perhaps. Which brings me to my talk, which I'll be focusing on headaches and fibromuscular dysplasia. I'm a vascular neurologist, and whenever I get a call about a patient who has FMD, usually it's more about they have a carotid artery dissection or a vertebral dissection, they might have a TIA or a stroke, and those are more urgent and kind of time-pressing things, but a lot of patients kind of undergo some other neurological symptoms, and I'll kind of focus a little bit on that today. So we're talking about the pathophysiology, kind of what our understanding is about headaches and why patients with FMD get headaches. What are the clinical presentations when they're having a headache? What does it feel like? What are the management options for these headaches? And at the end, when should somebody really be seeing a neurologist, right? So we'll start with a question first. We've kind of gone over some of these numbers in the morning, but what do you think is the prevalence of headache in patients with FMD? How many patients with FMD do you think have a headache? So we see a lot of response actually say 40 or 67%, and the answer is 67%. In the largest US registry that we have so far, I know we have an ongoing registry with more patients perhaps, but it found almost 2 out of 3 patients who had FMD had headaches. And there are other studies that have smaller numbers, but have reported almost 70 to 80% patients with FMD reporting a history of headache, which pretty much the take-home point. It's very, very common for patients with FMD to have a headache at some point. And which brings us to, why do patients with FMD have headache? And as we have kind of talked about other aspects of FMD so far, it is kind of multifactorial and not something that is very slam dunk established why it happens. Some of the mechanisms that we think likely causes these headaches are, number one, there is disruption of this laminar blood flow. When you have these blood vessels that are nice and smooth, you have what is called this laminar blood flow, where you have a channel that's kind of in the middle, the surrounding channel kind of outside, which is kind of, when you think about kind of, so let's say water kind of flowing through a smooth pipe. Now, when there's kinks or when there's narrowings in that passageway, that kind of disrupts how smoothly this blood is flowing. And ultimately, that does have downstream implications when the blood is flowing all the way from the heart up to these larger vessels in the neck and smaller gradually all the way up to the brain. And that is thought to be playing at least some part in producing the neurological symptoms because of FMD. A lot of patients have uncontrolled hypertension. It could be secondary from the renal artery stenosis. It could just be essential hypertension from your traditional risk factors like smoking or dietary or lifestyle factors, for example. Some of the other proposed mechanisms, interestingly, is that because FMD does tend to affect these carotid vessels, what we call extracranial outside your skull bone, specifically in the carotid arteries, that's where we have what is called the sympathetic nerves. These nerves actually do control what is called the autonomic nervous system, or basically the tone of how your blood vessels constrict and relax in response to certain stimuli, for example. Now, normally that kind of controls things like your flight or flight response. If you're scared, if you're in a situation, your body tenses up, you respond to that accordingly. If you're in a more relaxed state, your blood vessels kind of will be looser, generally speaking. But because of FMD, if it specifically affects that part of the carotid, which is involved in these sympathetic pathways, then how your brain is responding to a lot of these external stimuli may be very different than if in case of a normal situation, for example. And then ultimately, a lot of what this leads to is what is called heightened dural pain sensitivity. Believe it or not, your brain actually does not have any pain receptors whatsoever. So if you actually get a brain injury, which is inside the brain and confined to the brain tissue, you actually don't feel any pain whatsoever. A lot of the pain actually comes from the coverings that surround the brain. These are what we call meninges, or one of those is the dura mater, which is the outermost or thickest protective part of those coverings. And usually this is where the pain receptors are. Now, a lot of understanding of headaches and migraines and pain pathways in general has focused that it's these pain receptors that get either overstimulated or they respond abnormally to normal stimuli, and which is what leads to the pain. So ultimately, all these factors ultimately lead to a place where a lot of patients with FMD, because of these varying reasons, eventually get headaches, right? So clinical presentation, before I move forward, I just want to get a show of hands. How many people in the audience actually get headaches? That's kind of close to 80, 90%, right? Now, I'm presuming not everybody has FMD, right? And that's one of the important takeaways, that not everybody who has a headache does have FMD, but people who have FMD will very frequently get headaches, right? So what are those kind of, as Dr. Kim mentioned, what are those symptoms and what are the signs, right? If we kind of try to elucidate those, as we've kind of talked about, the most common symptoms are hypertension, your blood pressure is high, patients get headache, and this pulsed tinnitus whooshing sound in your ear that's there, right? Now, in that US registry, when I looked at those 67% patients who had headaches, they also looked at how frequent these headaches are. And interestingly, almost more than a quarter of patients said they had a headache every single day. Another quarter said they had headaches at least on a weekly basis. So more than 50% patients had headaches more than once a week. And the other half had less frequent headaches, for example. So the other takeaway is that in addition to a lot of patients having headaches, these actually do happen very frequently. As a stroke neurologist, when I'm on call overnight, my 4-year-old often sits with me when I'm looking at these scans in my offices. And she often points at, hey, Dad, is that the eyes? Is that the nose? And I was kind of surprised one day, but when I was looking at one of these scans, where kind of these arrows point those beating, as we've seen on other pictures as well, she kind of said out those words, like she knows nothing about this, but she literally says, doesn't that look a little beady? And I'm like, yes, it does, right? But a lot of times, what I see as a neurologist is patients might have headaches, patients might have tinnitus. They obviously, a lot of patients have high blood pressure. They may not be diagnosed with FMD yet, but they do get scans for different reasons. They might have just have come into ED because of a fall. They went to see a neurologist because they're having frequent headaches. They went to see a neurologist because they had some other neurological symptoms. And sometimes, or more often than not, they end up getting a scan and we see these findings there. And that's where, as we kind of mentioned earlier, we're again trying to figure out, is this like an asymptomatic presentation that you do have FMD and haven't had symptoms yet? Or you've had symptoms, just haven't been able to put all those pieces of puzzle together and have a conclusive diagnosis, for example, right? So when it comes to those headaches, one of the things that we try to distinguish from a neurological perspective is, besides the headaches, a lot of time patients have different neurological symptoms. And it becomes a little tricky because you can really have TIAs or strokes, which is technically, when we say that's a vascular phenomena causing interruption of blood supply to the brain, which causes those either transient or permanent neurological symptoms, be it affecting your vision, your speech, your language, be the ability to move or feel things, right? A lot of times patients with migraines may have similar symptoms as well, that they might have a headache. Sometimes they may not even have the pain part, but they have these transient focal neurological symptoms. And we try to distinguish, are those symptoms more suggestive of a migraine, because the treatment for that may be very different, which is, are you really having a TIA or warning sign of a stroke? And again, that's a very different treatment paradigm itself. right? So what we often keep in mind from a clinical perspective in terms of specifically headaches are what are the warning signs of what we call secondary headaches, meaning something bad is going on with the brain. And they use this acronym called SNOOP, which stands for systemic symptoms. That if you have things like fever, weight loss, something else going on along with the headache, other neurological symptoms, when we say focal deficits, we're pointing to not being able to see from one side, not being able to speak, your face is droopy, you can't feel or move one side of your body, you're not able to walk all of a sudden. Those are all concerning signs. Something called the Horner syndrome, which is again, these are clinical signs that we see objectively on our evaluation. If somebody has a droopy eyelid, they are not sweating on one side of their face, they actually might have some local pain on one side of the face and neck as well. And then their eyes, their pupils, actually one side becomes a little bigger than the other side, for example. That itself is a sign that that sympathetic nervous system, which is along the carotid artery, is likely affected either from a dissection or some other pathology, or sometimes it also could be a sign of a stroke in some part of the brain that causes that injury itself. Um, Something called acute vestibular syndrome. A lot of patients kind of present with dizziness. A lot of patients describe that spinning sensation. We often use the term vertigo. If somebody has acute onset of vertigo along with headache or some of these other neurological signs, that's again a very concerning presentation. The other two O's, one of them stands for what is called onset, and specifically a term we refer to as thunderclap headache, meaning it is very different than the other usual headaches that patients have. The hallmark being this goes from 0 to 100 in less than 1 minute. So when it peaks abruptly, when you're like doing something and all of a sudden this hits you like, oh, this is the worst headache of my life. This came on so suddenly and severely. That's a thunderclap headache. Again, a warning sign that this needs prompt attention. Um, if somebody older than 50 starts having new onset headaches, you've never had headaches in your life, and now all of a sudden you start having headaches, that again is a red flag that needs to get evaluated. And then at the last, the P's kind of stand for a few things, but a pattern change. You kind of know your typical headaches, and now what you're experiencing is very different. If there's a postural component, meaning you are okay when you lie down, but you have a severe headache when you stand up, or vice versa, that again is concerning for something. If you have a pulsatile headache, meaning that that headache is kind of pounding, and you kind of feel that pain along with your heartbeat, for example, that again is a worrisome sign. Any headache in pregnancy, again, usually is a worrisome sign, although a lot of them can still be benign. And then if it is clearly precipitated by something called the Valsalva maneuver, when you're straining, for example, and you're kind of pushing, your pressure inside the chest goes up, and that actually affects kind of how the blood is flowing to the brain, for example. But if you have a headache that comes with any of these signs, that is always a warning sign that does need to be evaluated. Now, the different headache subtypes, when we talk about patients specifically with FMD, half of those patients characterize migraine types. When we refer to migraine, the definition of migraine, it has to be at least 3 different attacks, which kind of follows a certain stereotype. The pain can be different. A lot of people might describe a pressure-like pain. Some people describe this kind of pulsatile pain, like a throbbing pain. Some people describe a severe pain. The kind of pain doesn't kind of describe migraine itself, but it's more about how frequently it's happening, where it's located, and most importantly, what are the other associated symptoms with that. And the International Classification of Headache Disorder Society, it has a definition that says at least 3 attacks which fulfill the pain along with the 2 out of 3 other criteria. Those specifically stand for severe nausea or vomiting with the headache, intense sensitivity to light or sound, what we call photophobia or phonophobia. And the third thing is actually not being able to carry out your physical activity. And a lot of patients who have migraines will actually tell us that, when I have this, I really have to stop what I'm doing. I really have to go lie down. I can't work. I sometimes can't drive. I really can't go along with my day, for example. Again, these headaches may happen for 30 minutes, sometimes 2 hours, sometimes the whole day, for example. So what really helps us is all these characteristics of headaches to really see, does it fit in that migraine subtype? Is it more like what we call a tension type headache, where you kind of just feel this kind of band-like pressure sensation over your head? There are some other kind of classification of headaches as well. But again, it's all these other features that are very helpful for us. Some of the patients, about 10%, did report some association with menstrual cycles, which is important because we kind of heard there's definitely a higher incidence in women when we talk about FMD, but itself, menstrual cycles and migraines also have a lot of hormonal component that leads to higher incidence of migraine headaches during those specific times of the month, for example. And then one thing I was surprised by, again, this is registry data, but despite almost half of these patients having frequent headaches, only about 15% patients were actually taking a preventive medication, right? Um, the other take home from the registry was that those patients with FMD who had headaches tend to be younger at the time of diagnosis. They had a lot of dizziness, a lot of that pulsed they're more likely to have a history of dissection and also more likely to have a history of depression. Again, is it more one causing the other, or are they both just kind of happening at the same time? We don't really know that part, but that's kind of what we saw from that big US registry data. So then when it comes to all the different kind of types of headaches that we talked about, I want to talk a little bit about kind of how we manage these headaches, right? And I want to start with a quick question here. And then with a lot of you who have headaches, I'm going to presume for a bit that you are a little bit familiar with these medications, but the question really is which of these medications should not be used in a patient who has FMD and is having a headache? So your acetaminophen is your Tylenol over the counter. Propranolol is a beta blocker. It's a blood pressure medication. Valproic acid, it's actually a seizure medication, sometimes used for patients with headaches as well. Indomethacin is kind of similar to Aleve or Advil, an anti-inflammatory medication. And sumatriptan is one of the medications that we use for typically migraine headaches. So the question is, which of this should not be used? Right. So it looks like most people said sumatriptan, which is the right answer. And the reason behind that is the mechanism behind sumatriptans is they actually constrict the blood vessels, and that is something that is contraindicated in patients with FMD because of the inherent nature of the disease. You don't want to narrow these vessels, which already are kind of abnormal to begin with, right? So in general, the data that we have, the actual guidelines and the consensus statements that we have don't have anything specific about what it should be done in FMD. It usually follows kind of how we treat migraines and headaches in general. And one of the things that I often get asked very frequently when we talk about headache management, and a lot of people rightly being concerned about, side effects of different medications, is what can I do besides medication to help my headaches, right? And whenever I give them this answer, it almost sounds very much like, all right, this is basic common sense, but this is not really the fancy kind of cutting edge answer that I was looking for, right? But really, when it comes to your brain, these are the things that kind of makes your brain happy and healthy, right? So good sleep hygiene is very, very important. Getting those regular 6, 7, 8 hours of good quality sleep every night goes a long way in kind of managing and preventing those headaches. Again, easier said than done. Identifying these triggers is very helpful. We ask all of our patients, whether they have FMD or not, to keep a headache diary because it really helps us understand, number one, how frequent these headaches are, what things are actually causing these headaches, what is the pattern, is something changing, and then also how are we responding to the interventions that we're trying, for example. So it's very, very helpful if you could keep a log, at least for a few months, to kind of see how these headaches are, what are causing that, and help us understand better, how can we, target them with specific treatments. Again, adequate hydration, good nutrition, again, kind of goes without saying, but I'm surprised so many times where people, and all of us are guilty of this, where we forget to hydrate very well or forget to eat very well, especially if you're, in the middle of something or, traveling or those things. And those often can be kind of very well these kind of possible preventable triggers that can kind of be a big a role of kind of causing these headaches and migraines in the first place. And then there's very good quality data about doing regular aerobic physical activity that kind of improves, again, your general cardiovascular risk, but also preventing headaches and migraines in general, right? When we come to specific kind of approach, I kind of put this chart out there, which kind of outlines what our strategies are, which basically divides what we call abortive medications, basically medications that you use when you have a headache to basically try and stop the headache, versus using what are called preventive medications. The general threshold is having more than 2 headaches a week. The graphic over here says at least 2 headaches a month. There's an increasing push in general in headache management that, again, the frequency of a lot of chronic migraines or headaches is under-recognized, and we should be more proactive in preventing them in the first place rather than chasing them with abortive medications. But the general practice, if you're having more than 1 or 2 headaches a week, which is basically at least 4 to 8 headaches a month, that kind of means we need to be working on preventing those headaches in the first place. If you're just having sporadic 1 or 2 headache every month, you can try something that kind of just, you take it when you need it, knocks the headache off, and you're good to go. The general approach is would we kind of use what are called these NSAIDs or non-steroidal anti-inflammatory medications, things like Advil, Aleve, indomethacin. In general, again, if there's any history of kidney problems, other contraindications, we prefer Tylenol as a more safer agent. And then if not completely resolved by that, then we typically use these medications called triptans. But as I said, for patients with FMD, that is contraindicated. So in general, what we've now moved on with some of the newer agents that are available are these what are called as a class CGRP inhibitors, or basically these are actual antibodies that inhibit some of those receptors that are controlling the pain inside those surfaces in the brain. These can actually be either oral agents that can be either, you can kind of take it intranasally, or these can actually be either monthly or 3 to 6 month infusions. So there are kind of different formulary agents available in this newer class, which ideally would be the best choice of abortive therapy for patients who have FMDs. And then if for patients who have more headaches, as I said, then we're specifically looking at certain class of medications to prevent headaches in the beginning in general. So as I said, Tylenol, NSAIDs, a lot of patients also have nausea. So if you happen to, for example, go to the ED with a severe migraine, often we will use these IV medications because the nausea part actually makes it hard to keep any medications down. Until we treat the nausea, the headache doesn't really get better, for example. The most exciting classes are these CGRP inhibitors, as I said, but there's a lot of promise in terms of how effective they are, although it comes with limited data in terms of what it really does for patients, and the long-term implications is kind of need to be studied. Although in the large randomized controlled trials that were done prior to FDA approval, there was no significant risk in general of bad cardiovascular outcomes, but there are ongoing surveillance studies. And again, so far, we haven't found any adverse data so far. And then in some cases, we use kind of a brief course of steroid just to kind of calm that inflammation, that pain down to stop the cycle of the headaches. When it comes to preventive therapy, I prefer kind of using beta blockers in this patient population most often, just because a lot of patients might have concurrent hypertension or other cardiovascular risk factors, and kind of kills 2 birds with 1 stone. And often these medications, we might just need a very low dose to really be helpful with headaches, for example. We do use a medication called Topamax or topiramate, which is kind of one of the better working medications for chronic migraine. One of the side effects, it can increase risk of kidney stones, for example. So we do want to be mindful of that. And then sometimes we use some of these antidepressants. They, again, do have a different kind of group of side effects, but general nortriptyline is kind of relatively safer. And again, a good adjunctive agent if you need some more help with kind of controlling the headache frequency. Again, the big promise here are with the CGRP inhibitors. And as you said, these are kind of in both classes. They can be used as both abortive medications, so you take it when you need it. But then there are also these kind of either monthly or 3-monthly injections that you can do that really kind of prevent these headaches from coming on in the first place. And then a very favorable management option here is Botox injections, which can be used for patients who have frequent migraine headaches. And again, the benefit is there's no systemic absorption, so you kind of avoid a lot of the other concerning side effects for these patients. Quickly going over, when do you refer to a neurologist? And I'll start with a question here. So when do you think a patient with FMD should go see a neurologist? Yeah, pretty much as you said, all of the above, right? So I was actually wondering, when should somebody with FMD see a neurologist? Because often we might be involved in different stages of the diagnosis pathway itself. But I asked my friend ChatGPT, and it gave me these 5 things, which actually makes a lot of sense. If you have neurological symptoms, which is concerning for TIA, something called amaurosis fugax, where you have vision loss in one eye only, when you have acute onset of vertigo, imbalance, the pulsatile tinnitus, or this new onset of worsening headache, that itself is a sign. These are things where you should actually go to the ER right away. If you clearly have somebody who has FMD and has existing CTA or an angiogram or MRI showing they have extensive carotid vertebral artery disease, either dissections or narrowing, those patients again should be followed by a vascular neurologist in terms of making sure they're on the right preventive therapies and making sure we can make an individualized plan when you get your surveillance imaging, for example. Again, it's a great idea to see headache specialists if you have refractory migraines, if your headaches are not controlled by standard over-the-counter medications. There are a lot of the newer therapies available, which actually can be safer than other things that you might try, and again, will be associated with better outcomes in the long term. And then again, as some of my colleagues had mentioned, sometimes we see these scans and we kind of question, is it really FMD? Is it something else? So in those cases, again, there needs to be a better collaboration, some more consensus in terms of what do we think really is going on? How do we put all those things together? Just something else that we're missing here that may be treated differently, for example. And then at the end, again, in general, I see a lot of patients, I used to see a lot of patients in the office who had multi-vessel FMD, where some of you mentioned you have dissection around multiple vessels. And then ultimately, you got to be careful about surveillance, because then your brain is kind of relying on just one or two good vessels to kind of supply the whole brain, for example. So do you need stenting? Do you need appropriate treatments? I think, again, those things need to be surveilled in the long term. But those pretty much are kind of most pressing reasons where you would want to see a neurologist. All right, we'll take some questions at the end. Thank you.